I still see there are quite a few students who have not turned their video on. Please turn the video on if you can. We'll start in a minute. How are you guys doing? Doing great. Good. All right. I've been seeing the students online now. Very good. One more request. Those who can, please turn your camera on. I still see some students have kept it off. Please turn that on so I can see the faces, and it will make the session interactive. I can, we can engage in the discussion easily if I can see you on camera. All right, so we'll wait one more minute. Okay, it's just 1 o'clock. So wait for one more minute before we start. You don't have any classes today to the masters as well, right? Do you guys have any classes?
No, not the
That's the
MS.
only class we today, right? Supplemental. Good. All right, so let's get started. Good afternoon, good afternoon, good afternoon, everybody. Welcome to our supplemental, first supplemental for pharmacology. Today's topic is very important as a tomorrow's physician for all of you. We will discuss. It is heavily based on math, so we will have some calculations today, mainly on the drug dosing, and the drug dosing could be a loading dose or it could be a maintenance dose. So I have two problem for each drug dosing process. For loading dose, there are two questions that we will discuss, and for maintenance dose, there are two questions that we will practice today. But before we get there, I would like to discuss about therapeutic drug monitoring, and you can see that on your screen. Therapeutic drug monitoring is a very important subject for all of you, because you have to understand this topic really well in order to apply it in clinical medicine, because once you start practicing medicine, you have to prescribe certain drugs that no matter what, you don't have too many options available. And you have to prescribe the drugs which are which have low therapeutic index, or you can say the margin of safety of certain drugs are very low. They are not safe to use on the long run, but you don't have too many options available, so you have to use those drugs in the clinical setting. So that's number one. Because you have to use those drugs, that drugs are widely used in many disorders, and there are no too many options available. So despite their margin of safety is very low, they have a low or narrow therapeutic index, you still have to use those drugs. Okay, and that is the reason why we have to understand the concept of therapeutic drug monitoring. Those, again, there are certain drugs in which you cannot quantify the response. the response of the certain drugs are not quantifiable, not measurable, not visible, and their therapeutic index are very low. The margin of safety of those drugs to use in practice are very low. They are not safe to use, but since there are not too many options available, and some of these drugs are very important to use in in a wide spectrum of clinical disorders, and some of those are life threatening disorders. So no matter what, you don't have too many options available, and you have to use these drugs. Okay, now what are those drugs? That's a question, because I just said that you have to use these drugs in the clinical medicine, and you don't have too many choices or options available as an alternative to prescribe other medications which are more safe. But obviously these drugs are less safe. Despite that, you have to prescribe these drugs. Now, which are those drugs? So those drugs are: number one, antidepressants, the drugs that we use to treat depression. It's a tricyclic and tetracyclic antidepressant drugs. And there is another drug called lithium. And I'm sure you might have heard about this drug, lithium, many of you. The lithium is also used to treat mania or maniac depressive illness, MDI, or to treat bipolar disorder. Okay, so antidepressants like tricyclic and tetracyclic antidepressants and lithium have low therapeutic index. Despite that, we have to use this drug in clinical practice. The other drugs that we have to use is anti-arrhythmic drugs or anti-arrhythmic agents. The drugs that we have to use to treat various kind of cardiac arrhythmias. Anti-arrhythmic drugs. The drugs that we used to treat congestive heart failure, or we can also use this drug as an anti-arrhythmic agent, which you learned it in first 2 weeks of physiology material. Can anybody tell me what drug is that you learned? That has very narrow therapeutic index, and we still have to use this drug to treat congestive heart failure. And what is the name of that drug? Anybody has any idea? Very good, Jay. Superb. Wow, you guys are great. It's a cardiac glycoside, digitalis or digoxin. Remember that it actually inhibits membrane-bound sodium-potassium ATPase pump in cardiac myocyte, but that drug we use that drug in congestive heart failure because it will increase the force of contraction by inhibiting this pump, and that will increase the cytosolic calcium concentration and will increase the stroke volume and cardiac output in a patients who have a congestive heart failure. So despite the therapeutic index of this drug is very low, the safety is not great, we still use this drug in certain cases of congestive heart failure. It's called cardiac glycoside or digitalis or digoxin, which you knew because you learned it in first week of material. Okay, so antidepressant, antiarrhythmic, lithium, cardiac glycosides like digoxin, and anti-epileptics. So there are drugs that we have to use to treat epilepsy or seizure, and in certain drugs in that category also have narrow therapeutic index, and you have to monitor those drugs concentration in the patient's blood round the clock continuously in blood, because that drug is very dangerous on the long run. So you have to monitor the drug concentration round the clock continuously just to make sure that you do not the drug concentration doesn't go above the therapeutic range. Above the That's why it's called that's why the term that we use is called therapeutic drug monitoring. So the drug has to be in therapeutic window. If it goes above therapeutic range, it's called supratherapeutic or toxic dose or toxic concentration. So you have to make sure that the drug doesn't go above that level in toxic range. Okay, so that's why we have to continuously monitor those drug concentration in patient's blood round the clock continuously, on a regular basis. The other drugs are aminophylline or theophylline that we use to treat bronchial asthma. So it's called anti-asthmatic drug. It's not all, but some of them. We have to monitor those drug concentration as well. And other drugs are aminoglycosides, which is antibiotics, uh, uh, which uh, which we have to be very careful, especially the patients who have a kidney disease, renal failure, for example. Then we have to be very careful when we use those drugs. And if we have to use it, then we have to monitor those drug concentration in the blood round the clock. Okay, and penicillin in certain cases, those who have a history of allergy or anaphylactic reactions, that can result in anaphylaxis. So those who have a history of penicillin allergy or beta-lactam antibiotics allergy, you have to use this drug very carefully in those kind of patients as well. Okay, so being a physician, tomorrow's physician, you have to understand the concept of therapeutic drug monitoring, because you have to prescribe the drugs, and you have to understand the concept of drug dosing, which is loading dose and maintenance dose of the drug. Okay, so with that foundation, with that idea, I will move forward. uh, this is the set of learning objective, and as we discussed yesterday, when we talk about the calculation question, math based questions, this is heavily math based session today. So I will just give you this question first. I'll start the poll. You can try to calculate based on your knowledge and understanding from the video, from the resources that I have provided on Canvas. So based on that, just try to answer the questions. First, we will do the calculation blindly without understanding. Just do the calculation, and then we will try to understand, and we will try to connect it to the clinical application. Then we'll discuss why you have to know this calculation. What is the clinical application of knowing this calculation? So this is the first question on loading dose. So there are the first two questions are on loading dose, and after that we have two more questions which will be on maintenance dose. So this is the first question on loading dose, where I'm asking what is the VD, which is called volume of distribution in this particular patient. Okay, and I'll start the poll now. Uh, I mean, poll is just, I'm not going, I'm not going to calculate any points or grade this session. It is just to, keep our, you know, my eye on the time and how many people responded correctly to these questions. I just want to know that. I just want to know that how many students are proactive and come prepared for the class. You can see the question, right? Good. I just want to see who is here and who is not here from MS Students program. So I'm just seeing everybody. By the time you respond to this question, and for the DO program, is optional for DO, but it's required for the MS. I see some DO students there too, which I appreciate that. Thank you for coming. And I definitely encourage students, DO students who are not here today, to watch this recording, because it is very important for them to know that as a future physician. And also it is very important for our exam on 25th. So I definitely encourage students to watch the recording later on. It's a very, very important session for exam, and also for the board exam, and also as a future physician. Okay, you have to know this no matter what. But
Dr.
that is one of the
Shah,
reasons why I'm recording this session, so I can provide the recording later on to all of you. So you can view the recording later on. But still, I would like students to come. Yes, Jasmine.
Hi, Dr. Shah.
Yes.
When we went over the drugs a minute ago, will we get a slide with all of the drugs we should be familiar with?
Well, that you don't have to know for the exam, so that's why I'm not providing slide for that. That is just the foundation. I just want to give you an idea that why we have to know this, right? If I will just talk to you guys in vacuum, doctors say, okay, but why we are learning it, right? So only cardiac glycoside is the only drug for you, all of you to know at this point of your career, Jasmine. Okay, but I just have to give some context, right? If without context, I just cannot talk, because otherwise students will think like what I'm talking. But now you know why you have to know it, when I discuss in some context to the clinical world, right,
Thank
Jasmine?
you so much.
Well, it's a good question. So whenever I don't put something in the slide, or if it is not there, I'm just telling that to everybody. If it is not there in my high yield summary slides or my toolkit that I'm posting for every exam, uh, uh, make that means it is not important for you to know for the exam. Okay, all right, everybody. So, but I have to tell, because I am also teaching to the DO students, and for the DO students, it is more important at this, even at this stage, because they will be in second year next year, and they will be exposed to clinical world, and they have to know that, and they will know throughout the first year, but still, at certain point you have to start, right? At They have to know at certain point. So why not now? Why not now? Yes, you are correct. Quiz. That is great. Good job. I'm seeing the chat now. Very good job. All right. So now I'm gonna. Do you need more time? It's very simple question. I know it's math, but this doesn't require that much of intensive calculation. It's a very straightforward, simple math. This particular question is not that much time consuming. All right, and I'm not going to we are not going to count any points for this, so don't worry about that. We are here. Supplemental is all about learning. Interactive is also for that, but we are more focusing supplemental about learning. Understanding the concept from a grassroots level or from a ground level. Okay. All right, I'm going to stop the poll. Let's see how the students did. Just out of curiosity, just to find out. All right, good job. A lot of students responded to that question correctly. So any volunteer who can explain that to me? Who is the volunteer here? So many of you have responded to this question correctly. So anyone, any volunteer?
I can explain it.
Of course, thank you.
Um, so you just take the weight, 100 kilograms, and multiply it by the given VD, which is liters over kilograms. So then you cancel out the kilograms, and you're left with 20 liters.
Excellent, very good. And are you a DO or MS students? Because your camera is off. I don't know.
Dio, sorry, I'm like.
Very good. No, thank you for coming, Elijah. I appreciate that. And it's a good job. Superb. So you look, remember that in the exam, I may give you a lot of data. You have a lot of data in the STEM here. You don't have to apply all the data for the calculation. Remember that. Okay. You only have to apply the data that is required to get the answer. Okay. So there are too many data that you don't have to apply all the data to get the answer here. Number one. Number two, and Elisa said that very nicely. Remember that, and this is called, I have posted these tips and tricks already on Canvas in my toolkit. So remember that you follow that very carefully, and make sure that when you do the math now or in the exam, you write down each step, each micro step when you calculate, when you do the math now or in the exam. Because even I can make mistake if I do math back in my mind, if I do not write it down on the paper. So use a scrap paper now or in the exam, and make sure you write down each and every step when you do the calculation. Because how smart you are or how smart I am, you all can make mistake in math if you do not put it on the paper, if you do not write it down on paper. Number one. Number two, why I'm telling you this, because when you write it down, like when you write down what first you have to write down. When you write down what you want to find out, VD in this case, for example, then you will come up with a formula, that what formula you have to use based on that. Okay, and then you will plug the value of the number that is given in the stem in the formula here to get the answer. Okay, after that, you have to make sure that you have to look at the unit. So make sure when you plug the value in the formula here, you put the unit with every step. Okay, do not just plug the number. Make sure when you plug the number, you put the unit with that. Why I am telling you that? Because when you put the unit with the number, you will find out whether you have to convert the unit or not. It is very important whether the unit requires conversion or not. Okay, that's number one. And after that, you will find out when you put the unit with each step, you will find out, you will know which unit will be cancelled eventually. Okay, and whatever the units are cancelled, finally whatever unit is left over, that is the answer, right? That is the answer. So you have to go step by step process. So in this case, you have to find out VD and look at VD is, in this case, you don't have to use the formula, number one, because you don't, that's why you will find out, because you don't need to use the formula. The man weight is 100 kilogram. That's the reason why I'm telling you to put all the steps. So what is the weight of the man is 100 kilogram, and I already already gave you the VD in the stem here, which is 0.2 liter per kilogram. So it's very simple calculation. 0.2 liter times 100 kilogram, right? So put 0.2 liter per kilo times per kilogram, which is VD here, and times 100 kilogram. So when you put the unit, you know the kilogram here is numerator and kilogram here is denominator. So you are cancelling kilogram automatically. 100 times 0.2 is 20, and L is the one which is left over as a unit in the final step. So it's 20 liter. And then you can think about that, it makes sense because you are calculating volume of distribution. So volume is always in liter or milliliter, right? It makes sense, right? So you can think later on like, okay, I get final answer in liter, and what we are looking over here is volume of distribution. So that makes sense to me. Its VD is volume of distribution, and that has to be in liter. So I can see why it is in liter. Everybody following it now? If anybody has any questions now, they can ask me before I move forward. This is very straightforward question. The VD is already given in the stem, 0.2 liter per kilogram, and you just have to multiply that with the weight of the person, which is 100 kilogram. 100 times 0.2 liter divided by kilogram. So kilogram is cancelled, and whatever is left over is VD, which is 20 liter in this case. Is everybody clear? Any follow-up question on this? Please feel free to ask me the question. It's your chance to ask question. Yes, you are correct, Digo, and we'll talk about that. As I said, like let's not think about the concept at this moment. Let's first focus on the calculation part. How not to miss any concept on calculation part. How not to miss calculation in the exam, and how otherwise you will lose the points for that. So make sure that we first get the calculation right. Okay, and then we'll discuss about the concept as we discussed yesterday in our class, that why we are learning it. We are not learning anything in the vacuum. There is a reason why we are learning this concept, and then I will try make the clinical connections application of why we are learning this calculation. Yes, Andrew.
Oh, yes, thank you, doctor. I just had a quick question. Is anytime volume of distribution, is that affected by bioavailability or no?
Will that affect my bioavailability or not? No. No.
Okay, thank you.
Okay. Because your voice was breaking up, so now I hope I heard you correctly. So did I answer your question basically?
Oh, yes, thank you.
Yeah,
Thank
okay, all right. Because your voice broke up. I didn't hear in between, but you are good. All right. So no, you don't have to worry about uh, this bioavailability when we get to the VD part. Okay. All right. Any other question to anybody? All right. Let's move forward. Next question. I'm starting the poll now. The reason why we don't take, Andrew, bioavailability into account when we have to calculate VD, because for VD it's all about intravenous dose administration, and intravenous is always 100%. Okay, make sense?
I have a quick question.
You follow that, Andrew? For the VD, when we calculate VD, it is always drug administered intravenously divided by plasma concentration of the drug. So we don't actually take into account that thing because it is always 100%. We are injecting intravenously when we calculate VD for any drug. Yes,
Oh,
Erin.
thank you so much. Thank you.
Yeah, Erin.
Hi, I just had a quick question. So,
Yeah.
I got my answer for this one by assuming 100% bioavailability because it's intravenous. But for something, if they were to ask like by mouth, we would include that bioavailability in our final calculation.
Yes, that is
Okay.
true.
Thank you.
That will occur in the last step, which I have.
Yes.
Good question, Erin. And I have that question in the practice question in a Q bank, and I have that question also in the supplemental, maybe today or next time. So hold that thought, but you are correct. We will do that at the last, not now. Right. If you are giving it orally, you are correct. Very good question. Very good question. I love that. Again, you are DO or MS?
DO.
Very good. Very good question, Erin. It's very logical, right? Right? We discussed about that yesterday to some extent, because the drug will get will be metabolized in liver, right? Erin?
Yes, that makes sense.
That's why bioavailability will be decreased, right? So that's why you have to take into account when you give oral dose, and if you want to match with the IV dose. And I'm going to end the poll. Do you need more time? Anybody need more time? All right, I will end the poll. This is a little hard question. That's why I told you in the previous slide that you have to make sure that you plug the value and the unit at the same time during the each step of calculation, just to find out whether you need conversion or not, right? And if you need it, make sure you convert the unit in the same gender so you can cancel it out. Yes, Erin, you are correct. You put in the chat. Thank you. Do you convert microgram to milligram or milligram to microgram? We'll discuss about that. Okay, let me stop the poll first. Remember that you have to know where you have to convert from where to where. Okay, and we'll discuss about that with this question. Now let me stop the end the poll now, and let's see the result. Okay, I see that. All right, still people 52% responded to this question correctly, which is a very good job. It's not bad. It's not bad job. Now, second question on loading dose, and the answer is D, 200 milligram, and 52% of 96 students, 97 students responded to this question correctly. Any volunteer who would like to explain here?
I can volunteer.
Ishak, yes, go ahead.
So I took the 0.2, the VD, and times it by 50. Then I got 10 liters, and then I took the 20 microgram and then I turn it to mg per liter, and then I times it by 10, then I got 200 mg.
Beautiful, outstanding. And you plug the value with each step, right? You plug the unit and
Yes.
number, right? So then you know that, right, whether you need the unit conversion or not, right?
Correct.
So tell us that why you convert the unit 20 microgram per ml, why you convert that to 20 milligram per liter. Tell us that. Why?
I had to convert it to multiply it by the 10. I have to convert it to microgram to mg to plug into the equation.
Why? But why you converted that in microgram to milligram?
Mm,
You are there, but you are not clear in your explanation. Why you converted 20 microgram per ml to 20 milligram per liter?
You need the units to cancel out, and the
Exactly.
only in milligrams.
Outstanding, Miss. Outstanding, Miss. Superb. Because and you are right. I mean, Isaac, you are there, and I know you. It was back in your mind when you did the calculation because you answered it correctly. So thank you so much, everybody. Good job. Because the VD that you have is in liter, right, Ishak?
Yes.
Follow?
Mhm.
The VD that you have is in liter,
Mhm.
and the target plasma concentration here is in microgram per ml, right?
Mhm.
So you have to convert, because the VD is in liter, you have to convert milliliter to liter here, right? Now you can keep microgram as it is, and you can convert milliliter to liter, right? But it will be a cumbersome number, right? So
I see.
that's why you convert microgram to milligram as well. You follow, right?
Yes, yes.
So remember that. Now I'm giving you this trick for the exam, for now and for the exam. Remember that whenever you convert any small unit to bigger unit for only one step, whatever you say, we convert microgram to milligram, milliliter to liter. At the same time, you have to convert numerator and denominator. You have to convert both at the same time in one step. That means the answer will remain the same. You see my point. That's a trick. If it is 20 microgram per ml, it will be 20 milligram per liter. Do not do math now or in the exam to save your time. Don't do the math. Okay. Don't divide 20 by 1000 and 1 ml divide by 1000. Okay.
Okay.
Right. Because
Thank
that's the same number. You will get the same number if you just go one step above or one step below that unit.
Mhm.
You follow? So you
Yes.
are moving one step above this unit microgram to milligram. So at the same time, you convert milliliter to liter, right? So
Yeah.
that means the final answer number will remain the same, 20 milligram per liter. Everybody get it? So do
Thank
not
you.
do math in the exam. If you want to do it, it's fine. But you don't need to do the math, and maybe you can save time over here. Let's not waste time to do the math here. Okay. Otherwise, the math is very simple. You can divide 20 by 1000 and 1 ml by 1000 to get and you can 1000 will be cancelled. So final answer will be 20 milligram per liter,
Mhm.
right? So that's why we converted that, because the VD is in liter, right? Which is 10 liter, right? And then you plug the value of concentration here, which is 20 milligram per liter after conversion of units times 10 liter. We just simply use this formula at this point, and then we cancel liter and liter here, because this liter is denominator, this is numerator. So liter is cancelled. 20 times 10 is 200 milligram, right?
Yes, thank you.
Everybody got it? Now, one more trick here. I told you not to convert microgram to milligram as well. Why I told you? Obviously, one reason is that it will be a cumbersome number. Okay, so we don't want to ask patient to take a drug in 0.002 milligram. That's not good. So we don't want that to happen. But what is the other reason I converted microgram to milligram? Anyone? That's very funny. Why we converted microgram to milligram here? What is the other reason? Very good, Alan. Superb, outstanding. Yes, Miss. I'm sorry, I'm pronouncing. What's your name, Miss Messia?
You can just say Abraham, it's fine.
It's okay. Thank you. All right. Thank you. So you are correct, Miss Abraham. But what Alan said is very correct, very true. That you have to look at the distractors answer choices. The answer choices are in milligram, so you have to convert that in milligram. Very logical, right? Those has to be milligram. Those has to be in microgram, Miss Abraham. Those has to be in nanogram and picogram. So those can be in any of these things. Yes, milligram is very common. I agree, but it's not always a milligram. It could be microgram. I will give you a very good example. If somebody wants to use the inhaler for asthma, right? Like asthma, the dose is in microgram, right? So that dose is very small. So the dose is not always in milligram, but you are correct. Dose is most of the time it is in milligram. When you talk about the tablets, medicines, it's usually is milligram, but not all the time. But here we converted microgram to milligram. The other reason is because the answer choices are in milligram. Right? Everybody clear on this? Very good. Thank you. And are you DO or MS, Miss Abraham? You are DO or MS?
Yes, I sit up front with Alicia.
No, but are you DO or MS student?
MS.
Oh, good. All right. Good job. Good job, everybody. I'm happy that you are participating. That's the reason why I'm asking sometimes, because MS is required and you need to do well. It's competitive program. But I appreciate your participation because, and DO especially because they came. I'm sure they are tired, and they came and it's not it's optional class for them. So I appreciate who came from DO class as well, and I appreciate participation. I am very happy and very grateful for that. It's going to help you one day, in not only in the exam but also in the future. Okay, everything comes back. Hard work pays off one day. Okay, good job, everybody. Yes, Jasmine.
So just to clarify, when we're given concentration in microgram per milliliter, it will be the same amount in milligram per liter.
Very true. Very true.
I just
good. It's good thing you brought it up. I'll give you one more example.
Okay.
Just let's practice it. I'll give you some more example, and anyone can answer it. If I say 5 microgram per ml, what will be the answer in milligram per liter?
5.
Exactly, 5 milligram per liter, right? Remember, you have to also say the unit. Everybody, please make sure you practice that way. Practice is very important. What you learn, what you practice, you will put in the same way now or in the exam. So make sure what you practice, you will write the same thing in the exam or in the now. Make sure you say the whole thing. Just don't use the number. Use the number. Tell me the number with the unit. Okay, everybody. So 5 microgram per ml is equal to 5 milligram per liter. Jasmine, right? And it's very logical because you have to divide 5 by 1,000 and 1 ml by 1,000. You get the same number, right? Right. So that's why there is no need to do calculation and spend or waste time in that kind of thing in the exam, right? Right. Because it's time constraint in the exam. Some students need more time, especially the questions which are math driven, math based questions. Students need more time. So that's why I don't want to waste time like this. And it is also in my tips and trick that I posted, Jasmine, on Canvas and everybody. So make sure that you visit that tips and tricks on Canvas as well, along with the practice cubans. Okay, and hide slides. All right, good job, everybody. So now we discussed both questions about loading dose and maintenance dose. Okay, and sorry, loading dose, and we are good at that. We are discussing maintenance dose in the next set of questions, which we have 2 more questions. Now the question is that why we are learning it. What is the significance of learning loading dose? Why we have to know it? What do you mean by 200 milligram intravenously? Okay. Okay. In this case, I gave bioavailability here 0.50. Right? Do you think it matters here? Anyone? Before I get to the clinical application part, I want to talk about that. Do you think it matters because someone, I think Gary or someone brought it up about bioavailability? Do you think the bioavailability matters here in this calculation? Yes or no? Anyone? If you put in the chat, it's difficult for me to see the chat. Let me see that. Yes, Erin. It is IV. IV is always 100%, right? When I say bioavailability is 0.50, that means it is oral bioavailability. Okay. IV is always 100%. We talked about that yesterday because you put the drug directly into systemic circulation, bypassing the liver and the stomach and GI tract, so the drug will not get metabolized. All the drug is directly getting into the systemic circulation. Okay, 100% bioavailability. Very good job, everybody. Very good job. All right. Now, so that's why in this case, it doesn't matter. Despite I put it in the stem, it doesn't matter. Yes, you are right, Digo. It is only it is only applicable to the PO or any other route which is not intravenous, right? Other route also have a bioavailability. Oral is more significant because it will go through the bypass. It will go through the liver and all the, it won't bypass this thing. But some other routes the drug will get metabolized. So there is decreased bioavailability if you use any of the routes, but it will still be higher than oral, but less than intravenous. And we talked about that yesterday in our class when I give an example of sublingual drug administration, right? We talked about that yesterday. It's higher than oral, but less than intravenous. Okay. Now let's get to the clinical application part here. Why we have to know loading dose? Why we have to know this calculation? What's the clinical application? Why we are doing this? Anyone? And someone put in the chat. Okay, Andrew, go ahead.
Oh, to make sure that it doesn't go to toxic or deadly levels in the patient?
No, I'm asking about loading dose. So why we have to why we have to know loading dose? What is the clinical application? And in what under what circumstances, clinical circumstances, you have to use loading dose?
Professor?
I'm sorry, say that again.
May I answer?
Yeah, of course. Why not?
It's to loading doses used to achieve like therapeutic levels on like basically to achieve those therapeutic levels on the first dose.
I love it. Superb. So the loading dose, usually it is intravenous, but not always all the time intravenous. Very good job. So in order to achieve, I repeat, in order to achieve the desired therapeutic drug concentration in plasma, you have to use the drug in loading dose, right? When you inject a drug in a loading dose, you will achieve the desired drug concentration of drug in plasma right away, quickly, spontaneously, rapidly, right? So that's the purpose of knowing and learning or calculating loading dose, because we want to, in certain cases, in certain patients, we want to achieve the desired therapeutic drug concentration in plasma right away, quickly, spontaneously, in certain clinical conditions, in certain patients. And in that case, you have to use the drug in loading dose. Outstanding job. Great job. Thank you. That's the reason why we have to know loading dose. Now, under what circumstances we have to apply loading dose more often? Anybody? Not all the time, but more often. Any example? Yes. I don't know who raised the hand. Abdel?
It's me, Abdel.
Yeah, go ahead, Abdel.
Under emergencies, like when we have emergency situation.
I love that. So in case of emergency, when the patient is critically ill, right, Abdel?
Yes.
When the patient is critically ill in emergency room, or in case of urgency sometime, or mostly emergency, in emergency room, ER or ED, when the patient is critically ill, as I said, you have to achieve the desired therapeutic drug concentration in plasma for any particular drug right away to have the quick onset of action of the drug. So you can have an immediate action of the drug and it can save the patient. Because there are certain conditions which are fatal, which can be fatal, which have fatal consequences or fatal clinical conditions, or in that case, you have to achieve the drug concentration right away in order to treat the patients quickly as soon as possible. In that case, you have to give the drug intravenously in a loading dose, okay, to treat the critically ill patients. I'll give you an example now, because again, you don't have to know this for the exam. But when I give an example, I want to make it a clinical relevance here. So patients who has a MI, myocardial infarction or heart attack, and I'll try to give an example which you are familiar with, which you know probably, because there are so many examples I can give. Some people get cardiac arrhythmias or VFib or VTAC. Many of you knows about VFib or VTAC. In that case, we inject the drug intravenously and the name of the drug, and you learn that drug in first 2 weeks. During the first 2 weeks, you learn that drug, that we also use that drug to treat ventricular fibrillation or ventricular tachycardia, which could be fatal consequences of myocardial infarction. And the name of the drug is lidocaine or lignocaine. Are you able to recollect it, or does that ring the bell? Where do you learn this drug, lidocaine or lignocaine, in first 2 weeks? That we use to treat cardiac arrhythmias, ventricular fibrillation, VFib or VTAC, which is a life-threatening cardiac condition, and you have to give the drug intravenously, which is lidocaine in this case, and we give that in a loading dose to suppress arrhythmias right away, quickly. Okay, I can give you multiple other examples, but you don't have to know multiple examples. I'm just giving one example to establish the clinical context or relevance to this concept. Okay, anybody remembers that drug that you learned in first 2 weeks about lidocaine or lignocaine? What is the mechanism of action of that drug that you learned with action potential, to give you the hint?
Inhibit the sodium potassium pump.
I'm sorry, that's wrong. Who? But thank you for your try. Who said that?
Oh, Abdel again. Sorry.
No, sorry, Abdel. You are there, but it's not sodium potassium ATPase pump. What is lidocaine? What is the mechanism of action of lidocaine? When we go to the dentist, or for the tooth extraction or small surgery, local surgery, they inject the drug locally. It's called local anesthetic agent. Like for the tooth extraction, when you go to dentist, they inject the drug locally in the gum. Or for any small procedure, is called local anesthetic, that we also use in a different concentration to treat cardiac arrhythmias, VTAC or VFib, and it's the same mechanism. So what is that mechanism that you learned in first 2 weeks? Amir?
Yeah, it blocks the sodium voltage gated ion channels.
I love that. And can you turn on your camera?
Oh, yeah, sorry, my camera's not working right now.
Okay, all right. Are you or MS?
MS.
Very good job. It will inhibit or block voltage dependent or voltage sensitive or voltage gated sodium channel. Right? When you don't have a sodium, when you block this channel, there is no inward sodium current. And when there is no inward sodium current, there is no upstroke of action potential. When there is no upstroke of action potential, there is no action potential eventually. And there is no action potential, there is no sensory information carried to the brain. And that sensory information is pain. That is called pain, right? That's carried from the nerves to the brain, and we can feel the pain. That's called sensory information. That is carried by the afferent nerve from the gum, from the tooth here to the brain, so we can feel the pain. But when we inject this drug, it will block the sodium channel, and that will prevent firing upstroke of the action potential, and that's why there is no sensory information, which is pain in this case, is carried to the brain, and that's why we do not perceive pain, despite we have pain during that procedure. But we don't feel it because the sodium channels are blocked, inactivated. Okay. Yes, Diga.
In this questions, Tim, I don't see anything that refers to like elimination, half-life, or anything. Would that be like, I'm pretty sure we're not being asked for it right now, but I'm thinking about toxicity. You said that you want to have as full saturation of plasma as fast as you can, but wouldn't that also lead to toxicity eventually?
As I said earlier, I think you might have missed that. You have to achieve the desired. Have you heard that term, desired word I use? A desired means pharmacologically acceptable. A desired therapeutic. Yes. I use the word therapeutic also. So I use two words there. Desired therapeutic drug concentration in plasma, not supratherapeutic, right? It's desired.
Oh, okay.
That means it is recommended. It is acceptable. It is within recommended pharmacological window. Okay. Okay. Rico?
Yes, thank you.
No. Good question. I would like, I'm happy that you ask, all of you ask questions. I want you to ask questions. Otherwise, I will not enjoy my teaching. I don't want to come in the class or on the Zoom and just keep talking from my end. I want you to participate, everyone, and I want to keep the class engaged, and I want to understand how much you follow this information, so I can plan accordingly when I teach next time, or when I schedule any extra session, including my exam review session. Okay, I can help you accordingly. So I would like you guys to ask questions. That's very good. Thank you. I appreciate it. Good job, everybody. Now there is a myth or misunderstanding about that, when we talk about loading dose, people always think about the loading dose is always intravenous, which is not correct. Which is correct because in most of the cases, it is used for critically ill patients in emergency room. So usually we inject the drug intravenously in a loading dose. So we always think about that. But loading dose is not always intravenous. There are certain cases that we take the drug orally, and that is also considered as a loading dose. Okay. Now I'll give you a very simple example, and that drug is antibiotic that we use very commonly in clinical practice to treat sore throat or throat infection like pharyngitis or respiratory infection. It's called azithromycin or Z-Pak. I'm sure you might have heard about that, and some of you might have taken this for your own infection, to treat infection. It is widely used in practice. It's called, the brand name is Z-Pak, as you can see here in the bottom. So anybody can share their experience, those who have used this drug, that how they have administered this drug orally when it is prescribed to you. Anyone has any experience about this drug? How do you take it, if anybody knows about this? Or first, let me know, how many of you know about azithromycin? Rebecca, very good. I see Rebecca does know that. Would you like to say something about that?
Okay, so I was a pharmacy technician.
Very
Can you hear
good.
me?
I
Oh,
can
here's
hear
the
you.
camera. Sorry, I didn't have it open. Anyway, so I was a pharmacy technician, and Z-Paks are given 2 tablets on the first day, and then 1 tablet each day for a total of 5 days. And usually we used to recommend like at the same time every day, and it's given for as I believe it's an antiviral, right?
Antibiotic, antibacterial.
Okay, antibacterial. Okay.
No worries, but you are good. Thank you so much. So
Thanks.
see, now what she said, Rebecca said that they advise patients to take 2 tablets on the first day, and then second day, third day, fourth day, and fifth day perhaps. We don't go into fourth, fifth day. Usually we end at the fourth day, but sometimes we also go on the fifth day. So first day we advise patients to take 2 tablets at the same time. It's called at a state or concurrently. 2 tablets same time, concurrently, synchronously at the same time, and that's called loading dose. So that each tablet is 250 milligram. That each tablet is 250 milligram, and 2 tablet we ask patient to take it at the same time, and that is total dose is 500 milligram. 500 milligram, and that is called loading dose of azithromycin. Okay, and second day, third day, and fourth day we ask patient to take it only 1 tablet, and each tablet is 250 milligram. So first day patient takes 500 milligram, the second day, patient takes 250 milligram. Third day, patient takes 250 milligram. Fourth day, patient takes 250 milligram. Fifth day, patient takes 250 milligram. Okay, so first day is considered as a loading dose of the drug, which is double the dose from other days, which is 500 milligram in this case. 2 tablets, 250 milligram each, 2 tablets at the same time. We advise patient to take it. It is considered as a loading dose of azithromycin. Okay, it's called loading dose. Now the dose that patient is taking on second, third, and fourth and fifth day, it is known as maintenance dose, which we'll talk about that in the next 2 questions. Okay, so this is the example of azithromycin that people take it orally, and it is used as a loading dose on the first day to achieve the desired therapeutic drug concentration in plasma more quickly, more rapidly, or as soon as possible, to achieve the desired effects, to achieve the desired therapeutic effect in the patient more quickly, as soon as possible. Okay. I also use this example because this drug was widely used to treat infection during the COVID era to treat SARS-CoV infection. You might have heard about that. That even though it is antibacterial and corona is a virus, they found out that this drug has some efficacy against coronavirus infection. So it was widely used during the COVID era to treat coronavirus infection, SARS-CoV-2, precisely. That's the name of the virus, SARS-CoV-2, which results in corona COVID-19. And they started using these medications. Despite it is antibiotic, they found out there is some antiviral effect, especially the oral anti-corona effect with this antibiotic, even though it's antibacterial. So it was widely used in practice at that time, more even than now, even to treat corona infection during COVID era, which I think is very interesting to talk about. Just to recollect, what we went through, and this antibiotic was used during that time to treat, corona infection in a loading dose and maintenance dose, same in the same pattern, same fashion, same pattern. All right, let's move forward. Anybody has any questions before I move forward? Good. Yes.
How can an antibiotic act against a virus?
Say that again. So that's
can-
exactly I just told you. I just said that they have found out some similarity because it's actually antibacterial drug, as I said earlier. It is hardcore pure antibiotic. It is called macrolide group of antibiotic, and it is effective against various kind of bacteria, gram positive, gram negative bacteria. But despite that, they found it out accidentally because the people who have a corona infection, they just took it because they were sore throat. They thought it's a bacterial infection, but it is actually because of the corona, and they started feeling better. So it is more like a trial and error or observational effect. And then they went back and studied this drug effect of this antibacterial on corona, especially on coronavirus infection, and they found out this drug is efficacious to corona, but not as good as antibacterial. Digo, but it has some efficacy because it has some structural similarity that is also helping that drug to act against the virus to some extent. Okay, but not completely. Like it, because it is antibacterial. It is not antiviral, but it does have some efficacy against this coronavirus. Okay.
So it was by chance that the similarity,
exactly,
like,
it was by
the
mistake.
epitope was matched or something.
Yes, exactly. Okay, good question. I like it. Good questions. It's called evidence-based medicine. So when they found out, I don't want to get into that. We'll talk about that. But it's called evidence-based medicine. So they found out that from the clinical. After that, they run the whole clinical trial in different country because at that time everyone was desperate to treat these people. People who have infection, who have contracted coronavirus infection, because people are dying. So everybody was desperate, and they found out that this drug has some efficacy against corona. So they started using it, and it was helping to some degree, not completely, but to some degree. All right, good. This is very interesting question. This is little hard, and this requires intensive in unit conversion and intensive calculations. I'll start the poll now, and you can start. I'll give you more time for calculation. Okay, for this calculation. Again, I would really appreciate, maybe today it's fine, but going forward, I would like, you guys to keep your camera on, so I can connect with you easily and I can discuss. It can be engaged. It can be easily engaged and, interactive discussion. If I don't see your face, it's difficult for me to guess anything, what's going on. So I would like you guys to keep your camera on. And you guys are good looking people, You look, I'm not even good looking. I still keep my camera on. So I still have that daring to keep my camera on. So you can keep that on. Don't be shy, okay? I want to keep the class interactive and very engaging. I want more participation going forward. You guys are doing good job. I'm happy about that, but I need more participation. Other people, those who don't say, I want them to speak as well. Everyone has to participate. This is what I love. Don't be shy. It's going to help you. I'm trying to help you. That's a goal here. I see quite a good DO students are here too. I know, I can remember by their name now. I saw that. Very good. And very good job overall, everybody. You guys are doing great job. I saw the chat. So most of you are, answering correctly in the chat. I noticed that, which is a good news. Remember, follow my strategy. And I have published that strategy on Canvas, tips and trick, and all the strategy that I just explained to you. When you get to the calculation, plug the number with the units in the formula, and then you find out whether you need unit conversion or not. Convert the unit if you have to convert the unit, and then find out which units will be cancelled, and then whatever the unit is left over will be the final answer. Use this strategy all the time, not to miss the question now or in the exam. And I put the formula in the stem itself, so you can use the formula. Okay. You don't have to look in the book or anywhere else to search for the formula. Thank you for turning on your camera. I appreciate that. I'm asking to find out the rate of elimination of the drug. Okay. Whenever we use the term rate, it is always per minute, per second, per hour. Okay. It's the unit is always time on the time scale rate. Okay. So it's per hour, per minute, whatever. Rate of drug elimination. I'll give you 30 more seconds. Looks like you guys doing a good job. I can see the response. That's a wonderful job. Very happy. And those who are missing any question here, 1, 2, or 3, or 4, all questions, please feel free to reach out to me or watch this recording again, whenever you get a chance. I don't want you to miss any calculation now or in the exam, okay? Reach out to me if you need any help. Let me end the poll. Because as I said in my chat, your success is my success, okay? And I want all of you to succeed. That's my goal. Share result, very good. Well, there are still some students, as you know, as always, that happened in the previous questions as well, that they missed this calculation, and we will discuss it so they can find out why they missed it. Okay. Good job, everybody, so far. All right. Who will explain this step by step?
I'll explain it.
Thank you so much. Who is it again? What's the name?
Adaf
Yes, please. Thank you.
wasn't quite library, so I came out to explain
Yes,
it.
Adaf. Thank you.
Okay, yeah. So the way that I did it was like this. So first of all, I canceled the kilogram of the 100 kilogram with the kilogram in the CL. So I got 1000 milliliter per yes, 1000 milliliter, and then I converted
No,
that.
1000 milliliter per minute, right?
Yeah. And then
Right.
I converted that to get a liter. So I got 1 liter per minute for CL. So that was my answer for CL. And then I did the same thing for CP. And for CP, I got 0.1 milligram per liter. And the way that I did that was, so I multiplied 100 microgram by 1 milligram divided by 1000 microgram, which gave me 0.1 milligram per liter. And then based on the formula that I have, I multiplied CL by CP, which gave me 0.1 milligram per 1 minute. And then I multiplied 0.1 milligram by 60 minutes per hour. And then that gave me 6 milligram per hour. And then because the question is only asking for the loss of drug, we don't have to multiply that by 8 hours dose, I believe.
Outstanding. 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 It's a complete answer. I can say it's a complete answer.
Thank you.
But definitely, I have some follow-up questions to you, Sadaf.
Yeah.
So you can explain that to the audience here. And I know they did good job as well. But I just want to make sure that you also explain that why you converted units. For example, you start with the clearance first, right, Sadaf?
Yes.
So you talk about clearance first, and you converted. You multiply that with 100 kilogram, and then you said kilogram will be cancelled, right? So that is 1000 milliliter per minute,
Yes.
and that is 1 liter per minute. So
Yes.
can you explain that why to all of us why you converted milliliter to liter here?
Okay, so the reason is that first of all, because so milliliter have to be in liter, because in this third step we have to calculate for CP. So to be able to calculate for CP, we have to convert the milliliter in the CL to be able to calculate for liter in this third step for calculating CP.
Very good. So what she is saying is that what Sadab is trying to say is this: we have to convert this ml to liter for clearance because the target plasma concentration CP is in liter, 0.1 milligram per liter, right? So there is a unit here in liter here, and that's one of the reason. That's the reason why we converted milliliter to liter for clearance, right?
Yeah. And the
Good.
reason, exactly. And the reason that I cancel out kilograms, because kilogram is very, very big compared to micrograms. So going from kilogram to milligram and then microgram is easier, is much easier. So
Right. No, that's we don't have to convert kilogram here because the clearance is in kilogram, right?
Yeah,
110 ml per minute per kilogram times the weight of the person, which is 100 kilogram.
Yeah.
Right. I gave you the weight here, the man's weight. So that is just simple calculation, multiplication of 100 kilogram times this to find out the rate of elimination or clearance of the drug in that particular person. Right. Sadaf?
Yes.
So we get 1000 milliliter per minute. That is in 1 minute, 1000 ml of the drug the plasma is being cleared off the drug in that particular person, right?
Yeah.
Right? So that's why we just simply multiply that. So
Exactly.
that's okay. So now we know why we converted milliliter to liter. That's number one question from me.
Yeah.
Now why you converted minute to hour, and why you converted microgram to milligram? So let's go with the hour first. Why you converted minute to hour? Why didn't you keep it in a minute?
A minute to hour. So because the question wants the answer in milligram per hours units, not like
very good. So because the answer choice is in milligram per hour, right? So that's why you have to convert minute to hour here.
Yes.
Very good job, Sadaf. Now one last question for everybody. Why, and you can answer it because you explained it really nicely. Why you converted microgram to milligram here?
So why we converted microgram per milligram here. Well, again, because the formula, the question, like even if not paying attention to the question, all of the answer choices are milligram per hour. So microgram usually, in this question is not going to like give us any correct answer. So we had to like go convert.
Exactly. So in the answer choice, it's not microgram, it is milligram, period.
Yeah.
Right?
Yeah.
Right. So that's why we have to convert. Now, I saw the chat. So Erin, no, it doesn't have to be in liter per hour. It could be in milliliter per minute as well. As I said, rate could be minute per second per hour. and we discussed why we converted minute to hour here, Erin, because the answer choices is in hour here, right? Milligram per hour. That's why we converted. Okay, yes, good. Thank you. Good, thank you. Thank you for confirming that with me. So in this case, the rate of elimination of the drug is 6 milligram per hour, right? That means in 1 hour, 6 milligram of the drug. Now, what is the interpretation of that? Before I get to Jasmine, what do you mean by 6 milligram per hour here? How do you interpret that answer? Who can answer? Explain that. Yes, Jasmine. 6 milligram per hour. What does it mean by that?
Oh, I was raising my hand to ask a question.
Okay. So I'll come to you. Hold it. So what do you mean by 6 milligram per hour? Who can explain that? I mean, Sadaf did a good job. Yes, Andrew.
Oh, yes. So basically, from our initial loading dose, the drug will lose concentration at 6 milligrams per hour.
Excellent. Outstanding. I love that. Simple. Very simple interpretation, right? Right. Now, before I get to Jasmine, let me ask one more question to you guys, and that will basically explain everything on this particular question. What is clearance? That's hard, and you should know it in renal physiology. I know it, we are discussing it before that. What is clearance? Anybody has any idea about clearance? If you watch the video, how did you define clearance? Yes, Jasmine. Oh no, sorry. Jasmine has a question. How to define clearance? Anyone?
I could answer this question if
Oh
you
yeah, go ahead. Yeah. I'm sorry. Yeah, I didn't know.
clear-
I thought like, okay, go ahead.
Clearance is the kidney filtering out and like clearing or filtering out like the things that your body doesn't need.
Very good. You're right. It is. Look, when we talk about clearance, it is usually kidney, but not all the time. It is kidney. The clearance could be brain. The brain can have a drug clearance. Liver can have a drug clearance. Heart can have a drug clearance. The lung can have a drug clearance. But I agree with you to some extent that it is mainly kidney which is involved in drug clearance more than any other organ. Okay, which is true. But again, my question is that how do you define clearance? What is clearance? What do you mean by clearance? Because we talk about target plasma concentration in the previous question, loading dose. So you all know about target plasma concentration or desired target therapeutic drug concentration, which is same target plasma concentration or desired plasma concentration, same thing. But what is clearance? And I saw Miss Abraham raise the hand earlier. If she wants to answer it.
I was gonna let somebody else do it, but it's pretty much like it says on the thing, the elimination rate based off the concentration. So you want to know how, I guess how quick or how slow based off the concentration you give your patient, he's going to or she is going to eliminate the drug.
Yes, very good. So I just have a follow-up question on that to anybody. You can answer it, to anyone can answer it. So what do you mean by, okay, let's make it very simple.
Can I answer it?
One second.
Okay.
You can answer it, but hold on. If I say clearance is 60 liter per hour, right? Sadaf, you did that calculation, right?
Yes.
The clearance over here is 60 liter per hour. How would you interpret that? What do you mean by that?
So basically that means that how fast the body can remove the drug from the blood.
I love it.
Yeah.
Outstanding. Outstanding. Look, it is liter. So in 1 hour, in this case, 60 liters of the plasma or blood is being cleared off of the drug. Okay. In 1 hour, what is the clearance? Clearance means in this particular case, in 1 hour, 60 liter of blood or plasma is being cleared off from the drug. Okay, that is called clearance of the drug. Very good, outstanding. So that technically, if you want to define the definition, I can technically define it now. You know, the volume of the plasma or blood which is cleared off of the drug in a unit time. In a unit time, that is called clearance. That is the exact definition of clearance. The volume of plasma or blood which is cleared off of the drug in a unit time, in a particular unit time, that is known as that is defined as or known as clearance. Okay, and that is the purpose of writing the unit. Now you will see that why Dr. Shah keeps asking you guys to write unit, because when you write unit, you can also interpret what does that mean. Everybody clear, right? Looking at the unit, you can understand it. What does it mean? How do you interpret that particular variable in this particular formula? Okay, that particular parameter, clearance in this case. Everybody clear? Okay, all right. Now I have a question raised. Jasmine, go ahead, Jasmine.
I just wanted clarification. How do we go from 100 micrograms per liter to 0.1 milligrams per liter?
Good question. And Sarab explain that, but I will do it again, Jasmine. Don't worry. And this is a very good question, and I appreciate you are brave enough to ask this question, because there are students by experience. I'm not talking about your class now or any students here, because I don't know yet all of you, but for last 10 years I experienced that, and I appreciate that, Jasmine, you brought that up. There are students in the class that they do not even know this kind of calculation, and they do not even tell me that. And I appreciate that you are proactive, because if you are not proactive, you don't know what's going on here. Nobody knows about that. So I appreciate that you are very brave, and I love that. I want students to ask questions without any kind of hesitation. Okay, nobody's expert in anything, believe me, and everybody's good. Everybody's expert, everybody's good. There is no stupid question. Every question is a good question. So please don't feel free to ask me questions. Don't feel hesitant asking me any questions that you don't understand. Anybody doesn't understand it. Okay, now I'm coming back to you, Jasmine. So 100 microgram, even it's a small microgram is smaller than milligram. Agree, Jasmine?
Yeah.
So when you go from small to big, you always divide, right? You always divide. So 100 microgram divided by 1000, okay, to get milligram. Okay, okay. 1 microgram is equal to 10 to minus 3 power milligram. You can say that, or you can say 1 microgram is equal to 1 divided by 1000 milligram. Okay,
Oh, okay.
okay. When you go from small to big, you always divide. When you go from big to small, you always multiply. And I know you know that. It's not that challenging, but I appreciate your step forward to ask this question. So in this case, you convert 100 microgram to milligram. That means you have to divide 100 by 1000. Okay, Jasmine, clear?
Thank you. Yeah.
Good. I like that. Good. Perfect. Anybody has any follow-up question on this particular question? Anybody has any follow-up question? The next question is it will be very short and sweet and very easy. Okay, we'll finish that very quickly now. Just few more minutes to go. Anybody has any follow-up question on this concept? Now ask me, or later on. No worries about that. All right, let's move forward. All right, last question of the day. I'll start the poll. And this is the extension of the previous question. So you don't need that much time. Maybe you can answer it probably in less than 1 minute. I'm looking at the time, and I know it's 2:20 to 19 in my cell phone watch. But I just want to help you guys. Okay, I want you guys to do well in the next exam and all the exam. I just want to help you, and that's why I'm still here. Okay, I know we are beyond the time, but I don't care about that. I just care about your learning here, your education here. And again, if anybody has any doubt, anybody doesn't follow this, as I told you yesterday in the class, do not blame or do not curse yourself. It is hard. It is difficult. Maybe some of you may not have a chance to watch the video or read the material. So maybe they may not follow this immediately, but we will follow it eventually. Okay, it's just a matter of time. As I said, it's a learning curve. Someone picks up more quickly, someone doesn't pick up that quickly because you all came from different background. Okay, some might have taken this subject before, so they know it. Some might have watched the video, some have looked at my resources, some just came without that because of some other reason. They might have to focus on some other subjects, and I completely understand that. But I always encourage people to come prepared. But do the best you can. Okay. Oh, I'm sorry, Joy. I didn't realize that you raised your hand. Go ahead, Joy. You have a question now?
Yeah, so it's not directly about this problem, but it is. So like in general about clearance, why is it expressed as like this double fraction instead of like in reality in the bottom part, the minutes per kilogram in typically in math it would be shown as like minute kilograms, right? To like show that it's the fact that it's both in the bottom of the fraction. But why? Because normally a double fraction like that, like this one, would be, expressed, it means like divided by. So instead, the kilograms would go on the top of the fraction. You know what I mean?
Yeah, I got it. It's a good question. I would say hold your thought, and I will discuss it thoroughly again at the end of this session with you.
Oh,
okay.
okay.
All right.
Yep.
Okay. Don't worry about that. I'll get to that. Okay. But for now, you can answer this question. Okay. And then, because I don't want to hold other people here. It will be recorded anyways. Our discussion will be recorded. But I think it's very clear to most of all of the students. So we'll discuss at the end of the session. Okay, Joy? And it's a good point. All right. I'll give you 10 more seconds and then I'll turn off the poll, okay? All right, I'm ending the poll now. Wow, super, very good, very good. Now this is pretty straightforward. Who can explain that? Anyone beside Parambir Sidhu or Sadaf or anybody else would like? I just want to give everybody an equal chance or an opportunity to participate. So anybody else wants to participate, please. Otherwise, I will go to Parminder. Sorry, Parambir.
I can do it if you don't mind.
That will be great, Sonia. I appreciate it. Thank you so much.
Yeah, so my name is Sonia. I'm a DO student.
Yes, I see that. You put it OMS1. That's
Yeah.
good. I think everybody should do that. That way, I don't, I mean, eventually I'm going to remember everybody's name and what class they are in, because I just taught one class yesterday. But it's good to keep, on the window screen so I can see that. And I appreciate that, Sonia. Thank you.
Of course. So what I did is we found the rate of elimination in the previous question, which was 6 milligrams per hour. And then I just multiplied that by 8. So 6 times 8 is 48.
Outstanding. So good job, Sonia. A big round of applause to you. A big clap to you. Great job. Thank you so much. Then thank you for coming to the session. Even it's not required. Now, who will explain the concept behind this? Now, okay, Dr. Shah, I got it. I understand maintenance dose and it's too much discussion. I got it. It's really, I have clear picture now. But then why we are learning it? So anybody can interpret. What do you mean by 48 milligram? Like, what does it mean? Like, who can explain that? What is 48 milligram stands for? What does that mean? Yes, Parambir.
Does it mean how much of the drug is available in your body after a certain amount of time? So in this case, 8 hours?
No. I get that. But in the previous question, what Sonia said earlier, which is correct, that how much drug we are losing in hour? 6 milligram, right? We calculate that in the previous question, right? It's the same question. I just added one more part into the same previous question. So you are losing 6 milligram in 1 hour. Agree, Parambir? Now it's a question of I'm asking you 8 hour oral dose here, which is 48 milligram. What is that? Why we have to give 48 milligram? That's my question. Like why we have to give only 48 milligram every 8 hour? What does it mean by 48 milligram here? Yes, Diego, who raised the hand first, and then I'll go to Jasmine.
Does it mean that every 8 hours the patient is eliminating 48 milligrams, and for you to keep therapeutic levels, you have to replace those 48 milligrams?
I love you, Diego. I love you. You explained it completely, man. It's a complete answer. It's a complete answer. So Parambir and everybody, we lose 6 milligram of drug per hour in this patient, right? And in 8 hours, we are going to lose 48 milligram. And we are trying to calculate the maintenance dose here. On this basis, we will decide how much drug has to be given 8 hours, because that's what the patient is losing. Right? That's what the patient is eliminating. So patient is eliminating or removing or losing 48 milligram every 8 hours in this patient. So you have to replace what is being lost in the maintenance dose. Look at the name, maintenance dose. You have to just maintain the therapeutic drug concentration in plasma at target level by giving the drug which you are losing. So you just balance out the elimination by giving with this maintenance dose. So maintenance dose will balance out the elimination. Whatever you are losing, just replace it. So you can maintain the desired therapeutic drug concentration in the plasma in this patient. You follow that, everybody? Sonia, everybody? Because you are losing 48 milligram in 8 hours. That means if you want to keep the same drug concentration in the patient, you have to replace the same what is being lost. What is being lost? So that's called, you are balancing out elimination by giving 48 milligram drug dose at every 8 hour interval. So because you are losing 48 milligram. Everybody clear? It's not that complicated, I know, and it should be easy for you to understand, because based on this we can decide how much dose you have to give to this patient, because 48 milligram patient is losing 48 milligram every 8 hours. So you have to give the same dose to the patient at every 8 hours to balance out the elimination, to balance out what the patient is losing. You just have to replace what patient is losing the drug. That's it. That's why it's called maintenance dose, to maintain the drug concentration in plasma at target level, at desired level. Okay, you lose 48 milligram, give it 48 milligram, because that's what you are losing by elimination, by metabolism, and you have to replace that same dose every 8 hours to keep the drug concentration same in blood. Okay, whatever you're losing, just replace it. Whatever you're losing, just replace it with the maintenance dose. Okay. And I said, somebody asked me this question with the first or second slide about bioavailability, and this will also help them to understand. I put it 100% bioavailability. See, I put it because somebody can raise the concern to me that why 48 milligram, but you have to assume it is 100% bioavailability. That means all the drug that you are giving in a maintenance dose is all going to the blood. Okay, it's 100% bioavailable. Okay. So that's why I put in the stamp here, the drug is 100% bioavailable here. I put it here. All right. Now, if anybody has any questions, they can ask me. Follow-up questions. I mean, I will reach out to Joy later on at the conclusion of this session. You guys can leave. But if anybody has any other questions, I can answer the questions. If you don't have any questions, this was the last question of the day. You are good to go. Please feel free to leave. If you have any questions, please stay back and ask questions to me. But I don't want to hold you and waste your time, because that the session is done. We are done for the day.
Are you going to be on campus today, Dr. Swan?
I'm sorry, who's asking? I'll be there on Tuesday.
Got it. Thank you.
Yeah, if you have any questions, you can email me and I'm more than happy to meet on the Zoom. Hello?
Oh, yeah, I got it. Thank you so much.
Yeah, in case if you want to meet. Okay?